My name is George Gore. I'm the program chair for the New Jersey Black Issues Convention. Today, we're going to be talking about the loss of community hospitals in the minority areas. And today I'm joined by, and I'll let them each introduce themselves, Bill Bishop, who's with Homeland Security and OEM, Diane Keeler, who is a consultant and an advocate for the community, Bishop Disho James, but I'm going to let each of you introduce yourselves, and then we'll start from there.
My name is Bill Bishop. As George indicated, I work with the Offices of Homeland Security, Office of Emergency Management, and some of the things I do is intelligence and census tracking.
Diane?
Diane Kill-Atkins, New Garden State jurisdiction. We deal with community initiatives, education, healthcare, legislation, communications, etc.
Bishop James.
Bishop Jethro James, retiree urban development from PSENG, president of the Newark North Jersey Committee for Black Churchmen, community board advisor to Rutgers UMDNJ, community board member, St. Michael's Hospital. I chair the Human Service Advisory Council of Essex County, chaplain with the New Jersey State Police, as well as a licensed social worker.
Okay, we're going to start off with Bishop James, and we'll talk about some of the things that have been happening in the Newark area, some of the hospitals.
Well, George, as you know, they closed St. James some years ago. It was rumored that they were going to close St. Michael's. We found out that there was a deal being considered by those in power and politics to sell off the assets of the hospital to developers and sell the remainder to another large conglomerate healthcare center, take what they need and maybe give the community a clinic. We're able to work with several organizing groups of community folk. We're able to get 60,000 signatures that were verified, by the way. We found out that there was very little political will, not just in the city of Newark, but also all the way up to Trenton and into the federal government. But with that many signatures and a small pocket, politicians want to be elected. Then they found out that they didn't want the community group that had met with several vendors from the hospital. Again, politics got involved and they were declaring who could and who couldn't. We met by phone at that time with the Attorney General and the governor. And so the state of New Jersey pulled back its cover. We met with Prime Healthcare out of California. Thanks be unto God, we were able to not only negotiate the hospital intact, but we found a couple of local politicians who were willing to champion our cause in the political arena. We met with the unions that worked with that were dealing with the hospital workers, and together we put together a team. We sat and met with Prime Healthcare and was able not only to hammer out a deal to keep the hospitals open, to keep the workers working, but also we negotiated 2 board positions for folks from the community.
Well, to get the hospitals to do what they should do and to save St. Michael's, okay, and to get some other improvements. Let me move over to Bill. Bill, the numbers they're showing, like they said, the first hospital in New Jersey was in 1891. Okay, but they're telling me there's only 150 hospitals in the state of New Jersey. Is that an accurate number?
Actually, New Jersey has 113 total hospitals, And this is based on the New Jersey Hospital Association. This includes special hospitals. There are 72 acute care hospitals in the state of New Jersey. And New Jersey's membership includes 108 hospitals, plus affiliate members, including, let me give you all the numbers, because I'm gonna put out a lot of numbers here so y'all can understand the
Back
number.
up a little bit so I can see your whole face.
Okay,
No, up. Okay, there you go.
okay, so I'm gonna give you the whole thing. Let me set this up. I'm reading from my screen here, so give you the numbers that's out. Okay, so there is a total of 113 hospitals in New Jersey, including specialty hospitals. There are 72 acute care hospitals in New Jersey. New Jersey HA's membership includes 108 hospitals plus affiliate members, including nursing homes, home health agencies, long-term care hospitals, and other healthcare providers, bringing the total number count to more than 400. New Jersey Hospitals simply employs more than 150,000 individuals collectively. Healthcare is the largest private sector employer in the state of New Jersey and ranks second only to the government as the state's largest employment sector. All told, New Jersey hospitals provide $23.6 billion in jobs, spending, and other economic benefits to the Garden State economy. Then it goes down here. It says New Jersey hospitals provide about $1.9 billion in free and discounted healthcare annually to the uninsured, senior citizens, and those in financial need. New Jersey hospitals care for more than 15 million patients each year. New Jersey hospitals emergency departments provide care and comfort to 3.8 million individuals annually. New Jersey hospitals provide 2.8 million in community benefits annually, including health clinics, screenings, education, and free discounted care for the poor and uninsured. All right, so we're gonna get into some other things here on the New Jersey hospital statistics. The next one we're gonna talk about is the total amount of beds that the state of New Jersey has. And this is the managed care beds. And what we call these beds, they call staff beds per hospital. And in the urban centers, Newark is the largest staff hospitals in the state. And they're totaling almost, I'll give you the 3 hospitals that Newark mainly have right now. And I'll start with the first one here in Newark. I got a huge list here. So I'm going right down here. The first hospital is Newark Beth Israel Hospital. It has 467 staff beds. And where's the other one? St. Michael's Hospital, 147. And then Newark University Hospital, 367, which is the total amount of houses. If you add those all up, it's almost 1,000 beds, available staff beds in the state of New Jersey, in the state of New Jersey. The rest is smaller than that, other than Morristown Medical Care, which is only for Morristown, and that's the total of 669 beds. Other one is Patterson, St. Joseph's University Medical, and they have 688 beds. But keep in mind, they're the only hospital in each one of these cities. There's not additional hospitals. At one time, Newark had 5 hospitals, Motlin, and another hospital. There was at least 5 hospitals in Newark, almost averaging 1 per ward. Now Newark has 3. And I think they have been trying to close St. Michael's, which will almost only have 2. So I got other statistics here during COVID that they're saying that the average hospital in the hospital beds in New Jersey was, New Jersey could face 300,000 beds shortfall over the duration of the outbreak. And the total amount of beds that the state has is roughly about 23,000 beds collectively in the state of New Jersey.
So they've got 23,000 across the state?
Yeah.
So if we look at the minority cities like Newark, Camden, Trenton, places like Plainfield, Cape May, Atlantic City, you're saying, because I know Plainfield right now has 0, because we don't have a hospital.
Right. That's correct.
Okay.
That is
'cause
correct.
I looked at the numbers that we had 2 years ago, and 2 years
Yeah.
ago there was 150 hospitals. So
Right.
you're telling me we're down to 113 now?
Yes, we're down to 113. In fact, several hospitals are already filing for a Chapter 11 status, which Governor Murphy has mentioned about that and trying to reopen them. Also, he's trying to restaff some closed hospitals. I think there was 8 hospitals closed after the 2006 recommendation and plan. And this goes back to 1999. I sent some documents to you on this information covering the a legislation that was covered back in 1999, which was called the HMO Hospital Reform Act, which they were complaining about costs at the time, and the cost of health insurance was going up, and they wanted to reform the HMO. And one of the things came out of it was recommendations about the hospitals were part of the cost of the insurance. And so they sent this recommendation after it passed the Reform Act in 1999. And then in 2006, there's another report that I sent to you from the state. Where is it? I got it right here.
Okay. Why don't we go to Diane?
Mm-hmm.
And you're an advocate, Diane, for the Hospitals Association. Tell me what you think as an advocate.
Can you hear me now?
Yeah.
Okay. As an advocate, there are 5 areas that seem to be vocal point to hospitals: legislation, education, communication, insurance, and community assessment.
Mm-hmm.
And all of those areas have an impact on hospital closings. My advocacy is do the work before it closes.
Right.
If you're talking about healthcare empowerment, don't wait till it closes.
Right.
Do the work before it closes. Find out from a legislative perspective who the freshman legislators are that are supportive of healthcare, regardless of the issue of healthcare. Have them at the table with you and tell them what type of role would you be playing in terms of, if such and such a hospital closed, what would be your role if they're already a support? Because freshmen want a name for themselves. That's what I've learned anyway. Remember, my background is pharmaceutical, and I deal with across the board individuals from the training, education, all of it. But one thing when we dealt with advocacy, and that was my role outside of Hoffman LaRoche, when we dealt with advocacy, we began to find that people were not listening to people. People were not opening up and dealing with effective communications. One of the things that I know, like Bishop James said, petitions are key. Yes, petitions are key. Statistics, what you are giving out, key. Yes. But the other thing that's key is we need to learn, insurances play a role in that debt that gets placed on hospitals. So I talked to an executive insurance person, and I said to them, how do you deal with your formula? How do you really play out your formula? And this is what they told me. They said, number one, we look at, in fact, what was the medical expenses that we appropriated last year. Then we looked at our membership. Then we looked at what is going to be the medical appropriation that we're going to appropriate this year. And what is our membership projection? How many more people do we want to add on? Or how many people do we have? Given the COVID, how are we going to go conservative? What are we going to do with those numbers? The next thing they also said was they take those 2 pieces, put them together, and that's how they decide their rate increase. And I said to them, I know that once a formula is a formula is a formula, that in fact, there's a body of people within their environment that decide on that. I said, what can an advocate do? What's the most important thing an advocate can do, especially as it relates to insurance and closing? He said, number one, the most important thing a healthcare advocate can do is to educate people about comparing insurances. Never buy an insurance that you can afford. And a lot of people, the out-of-pocket expenses can be heavy. If I know I'm going to have surgery next year, If I know I'm going to have surgery next year, I need to start putting away money this year. Don't wait till you get the bill next year. Why? Because one of the pieces that hospitals say is that their debt is very high. And a lot of their debt is debt because of the fact that people do not pay or not wanting to pay. I said, how do you help educate people? And he said, and they say, if a group of people came to us and said they wanted a seminar, wanted a layman's term for insurance and how to deal with insurance, we would set that up and do that from a community perspective. But here's another piece, Brother Gore, that is very, very critical that people don't know about. If the medical expense, if they appropriated, Brother Bill, if they appropriated $5 million for medical expenses and they spent $2 million, they will take a portion of that and reduce your insurance policy. They will do that. They don't do it often, but we need to know under what circumstances does that happen? Does it happen under, like, is it happening now under COVID? Is it going to be, is it going to be in the future? How often? I don't think it happens often, but we need to make sure we have access to those opportunities. Well, we don't talk to the insurance execs enough. And that's one thing to talk about healthcare empowerment. You want to begin to talk to the upper levels, not only those that are in fact giving out the information, telling you how to get referrals, etc. We need to learn how to navigate through their systems. And Bill, we don't know how to navigate. Go ahead.
Bill, when the governor this year had a healthcare bill that passed, do you remember how much money that was? Do we know how much New Jersey got for COVID?
I have to look it up to tell you, but I heard it's in the millions. That was the supplement for the uninsured. That's from the CARES Act and from the Recovery Act, which covered most of the COVID vaccinations and testing. That's what that was.
That's how it wound up being free.
Correct.
Or close to free.
That's correct.
Okay.
If I may,
is that we have set ourselves on COVID, which is true, but there's so many other healthcare issues that are not being addressed because all of it, and rightfully so, our concentration should be on COVID, rightfully so. However, there's a lot of other people that have other types of cardiac depression, other issues that are not related to COVID, and they are losing out in terms of what and how they can alleviate their situation. Am I?
Bishop,
if I may, because Diane and I go way back.
That's right.
Some good stuff because we were in large corporations fighting for our people and explaining culture, if you will. And one of the things that she mentioned was insurance and meeting with the folks there. To give you an example, the cities like Newark, like Patterson, like Camden, like Trenton, and Atlantic City, large corporations are very much entrenched in there and on their boards and make decisions along with, they also sit on the same boards that deal with insurance. One of the things that we found out, not picking on any hospital, but in Bergen County, they were getting more money for the poor that was uninsured than they were willing to give in Newark because the formula was wrong. Diane mentioned that the formula was that if you have a hospital with X number of beds, whether you serve the poor or not, you got a piece of that pie. It was an equal split. And so myself and some other advocates went and we had to beat up on some legislators that said, wait a minute, if I've got 100 people that are uninsured, and for argument's sake, Bergen County has 10 people, why are they getting at least as much? And so that's the kind of advocacy also. And then look at, and as Diane said, we should be looking at COVID. But one of the things that we're looking at now, and everybody's talking about it because of the refusal of some folks that are supposed to have good sense and the effect of the psychosis that COVID has caused. They're now looking at the mental health piece. And then who's going to pay for that? And that's real tricky. Then also, you're looking at what happens when they pass something that's going to impact health. And I got to throw this in. Every association we're spending hundreds of billions of dollars to tell you to quit smoking, but we just legalized marijuana, which all healthcare industries say you're going to have psychotic episodes. Your heart's probably going to stop before you're 35. Your lungs are probably going to have some type of cancer. What is going to be the impact on the healthcare? And all the medical professionals have agreed that this is not a way to go. Where is it concentrated? In our communities, let's be real. The other thing that I found real interesting is when you talk to insurance carriers, they look at the community, they look at what the community does that impacts their health. My grandmother didn't know diabetes. She called it the sugar.
Yeah.
So they look at all of that. And even going back to what I was saying, just even with this latest bill, I met with some insurance carriers, Diane, to talk about what would be the impact, not just of the medical piece of what happens with the marijuana, because we know that now we have an opioid crisis. Didn't have one until the opioid left Bergen Street and Muhammad Ali Avenue, got up on 280 and drove up into Parsippany. Then we had an opioid crisis, if y'all know what I'm saying. And since this is the Black Issues Convention, I need to just talk about it. We need to have some real conversations. I asked the insurance company, what do you look at in this state, the highest insurance in the nation? You pay insurance by your zip code. You pay insurance by your zip code.
That's correct.
And so we need to educate ourselves to what they're going to do. And they said, well, if you open up the smoke shops in Newark and Patterson and places that they want, number one, we know that your people have been known for it. Not that the other folks don't do it, they just don't get caught or they're let go. We're going to ask the Insurance Exchange Commission for a 15 to 20% increase, not only in your medical, but in your auto, because this is what it does. And we don't do as Diane and I and others have done, and Bill, one thing in corporate, they crunch numbers. They look at numbers. And we as a people do not do our homework and crunch the numbers.
That's
the numbers say it's going to cost us money.
That's exactly what I'm talking about when I talk about membership. And when they talk about membership, that's exactly what they're talking about. They are talking about, and also it's very true what the bishop said. I live in Montclair. My insurance is different from somebody living in Newark. It's a shame to say it, but it's real. It's real. It's just real. Okay. I know of a person that they were advised, keep the address in this city. Don't change your address. Just let your mail continue over there because of your insurance will increase. That is so true.
Okay, so
this just a few more items. The other thing is, and Bishop touched on it, is healthcare literacy. We need to step up to the plate where it comes to healthcare literacy. And that's whether we're talking insurance, that's whether we are talking about the actual navigation going through that hospital process in terms of from the policy all the way down to the prescription drug. We have to do that. This is before they close. I am talking about sustainability. If we can't talk about advocacy unless we talk about sustainability.
One of the things we looked at was when you reduced the numbers from 150 down to 113, you increase the distance that you have to go to get to a hospital. So right. how do we affect the beds that were counted in terms of that distance? Is there any statistics on it at all?
Yeah, there are actually some. The rural areas, the average rural area was going 5 to 10 miles to get to the hospital. And this rural and suburban areas, we're getting to the hospital. The hospitals are strategically spaced out. In the urban centers, Newark has the most hospitals in urban centers, 3. Other urban centers have 2 or 1 major big hospital. And then the rest of the hospitals are spread throughout the state. Well, one of the things, several things that I want to point out here. First one, let's talk about numbers, crunching numbers. Your insurance is solely based off of your employment. Most people has employment insurance. And under the employment insurance, it's based off the numbers of people who are in your company. And insurance in the 70s, companies were employing up to 100,000 to 1 million employees. The largest corporation today outside of Amazon employs about 40,000 employees, considering making billions of dollars. So one of the things that is affecting your insurance is population and how many people are in the job market. And when I say that is that as time go on, we'll continue to downsize businesses to be smaller and nimble. And when that happens, the insurance for that company goes up because we have less employees in that company. For example, City of Newark, just the City of Newark itself went from almost 10,000 employees to 5,000 employees. And this is over a 20-year period. And the insurance costs went up as more employees came off. It also affects your retirement. So your insurance is still based on population and how many people in your company, and then it's divvied up among those people in your company, how much the rate would be. So
go ahead, I'm sorry.
In the past, most people paid 3% on the insurance and the company paid the other 97%. Now, the average insurance today for a single person filing for insurance is it's actually $1,100. If you do the 2% over time in 5 years, that's about $1,500. For a family of 5, that's almost $2,300 if you had to shop for your insurance. And so the companies had to put a percentage that what the employee will pay out of his pocket. And we're talking about a Class A insurance. Class A insurance means they cover almost everything with low out-of-pocket expenses. So they went up to 30%. So now 30% of per person is paying into the insurance out of the paycheck, and the company is paying the 70%. Keep in mind, your companies are smaller now. And when we talk about New Jersey, when we talk about Newark compared to Bergen County, the reason why Bergen County got more than Newark is because Bergen County combined the total population. And when they combine the total population, it comes up a little more than Newark's total population. For example, Newark's population was 289,000, now it's 311,000. And that's just for Newark as a city. Bergen County as a county comes up almost, I think 350,000 in total. And so because of the population count, that's why Bergen County got a better deal than Newark, the city. If it was by the cities in Bergen County, it would cost more. So what they did, they went with the Bergen County, and that's why they got a better deal. And that's numbers.
Overall, the wealthier communities have higher paying insurance people.
Right.
The communities that are driven by government assistance and federal assistance for the poor have lower insurance premiums, which also has an impact on hospitals. And when I say lower, I mean lower in the sense of there's supposed to be a higher level of sensitivity, not the formula itself. Not the formula itself.
Now you're talking about coverage, or you're talking about cost? Because
I'm talking about coverage and impact on cost. Absolutely, impact on both. Because I find that we don't educate ourselves enough. Once again, it goes back to healthcare empowerment. We need to really understand, and I think this is what this exec was telling me. We really need to look at affordability, but also we need to make sure we understand the packages that we're buying. And Correct. Many times we don't understand the package we're buying. And right. A lot of that has to do with the literacy the healthcare literacy that the person has, as well as who's selling it.
Right.
The other thing,
Selling it makes a big difference.
if I may jump in here, the other thing is the contracts that the hospital have with the healthcare workers. For example, in Newark, UMDNJ, the hospital, doesn't have not one doctor under contract. All the contracts, and I don't know if you knew this, Diane, all the contracts are with Rutgers University.
Oh, no, I did not know that.
All the contracts, I sit on the community advisory board, and they'll nod their heads. You right, Bishop. We don't have any idea what goes into the hospital's cost formula, where and here's a way, believe it or not, to boost Rutgers University on the backs of poor folks. That was the reason that they got away from the Newark agreement to start with. And now, in the time of COVID, all of a sudden it's relevant again. And again, this is about education. The other piece, there was another hospital that wanted to be named a triage center. Nobody has, unfortunately, the crime and whatnot. And if you get shot, stabbed, or cut, you want to go to UMTNJ. And that's a sad scenario, but that's real because they're the best at whoever did it. However, when we look at what's happening with our youth now, because that's a big issue, youth and healthcare, PSENG, when I was there, and I've been retired since '06, made a commitment, even though we knew what the numbers look like in Newark, and for childcare, and 1 out of every 5 children in the city of Newark go to sleep hungry, live in poverty, and we could go on and on and on. They decided to give $5 million to the Robert Wood Johnson Hospital for children, instead of spending a dime in Newark. And no one other than myself said anything. And then, of course, I would get told from the highest office in PSENG, you forget who you work for. And Diane, as you remember, in 2004, I brought in the Reverend Jesse Jackson because I trained you on your job and then you became my boss. The same thing happens in the hospital's foundation and different things. Also, and I mentioned foundation, you need to look at what is the role of the foundation in the hospital. There's a profit side of healthcare and a nonprofit side.
That's right. That's right.
Now, the hospital you're talking about was Trinitage. Trinitage was the hospital that tried to get the thing, and they were there in Elizabeth, and they were turned down. And the hospital association played a large part in that, and the community said nothing. A large part in that in terms of getting it done. Bill, you were saying, what about the numbers?
Well, the numbers affects a lot of things. And one thing that you two are referring to is that the coverage of healthcare and insurance. First of all, we came to Obamacare, and Obamacare, what everybody knows, was to allow you to shop for your own healthcare. Under that system, if you ever went through that system and try to compare prices, you can. And the prices are when you go to Obamacare and apply for healthcare to compare prices, you will not be able to compare price. They will not allow you to compare price against another healthcare to see if it's better. And the other thing I would tell you, the healthcare under Obamacare, the price changes from hour to hour. So if you go in there and apply for healthcare for coverage, say for a house for 5, and they give you scenarios, and they will give you a quote, you cannot hold that quote and compare it to another vendor because they won't allow you to do it. They won't even give you the quote unless you commit to signing up for the care. And I went to several of them just to see how that works out. And what I found out was that CARES Act, even though it's supposed to be great, one of the problems with the CARES Act is that when you log on as a person who's trying to shop for healthcare and compare, before you used to do it before the CARES Act, because I used to go online and compare my rates and how much it would cost me out of pocket, because I was a consultant. I wasn't working for a company. I was working for my own company, and I was shopping for my family. And then I know there's several packages. You got an A package, B, and C package. And you shop for what you want. And because I had to get the A package because I have 2 kids, and one of my kids needed a neurosurgeon, and that had to be covered. So when I shopped for it, I was able to compare the prices. Under the CARES Act, you go into that portal, you cannot compare the prices against one provider against another because they will not allow you to do it. And the price, you go in there and they'll tell you, well, if you don't do it within this hour, the price goes up. It's like Wall Street. If you ever went into the CARES, Obamacare, and try to shop for healthcare, it's like Wall Street. You cannot go in there and compare prices. So for lower income people trying to compare prices, it is one of the problems they cannot do. They cannot compare prices. It's a big problem. And that's why.
Yeah, they cannot do it. You're right. But there's a group that can do it.
Right. But
there's a group that can give you advisement.
Right.
You can't do it, but there is a group that can give advisement. The other thing I'm going to add on to what you're saying is,
do that. You should be able to do that.
But I would have to know that there's a group that's doing that.
Right. And a lot of people don't know that.
And I don't think that information has been fully disseminated, especially in the minority community.
No, it has not been disseminated. But let me just add this point. Brother Bill, the other piece in terms of the Affordable Care Act and Obamacare, Tennessee had the largest closing of hospitals, rural hospitals, in any state in the country because they refused the Medicaid portion. They didn't want the Medicaid portion. And as a result of that, they have the highest number of hospital closings in the country, i.e. in the rural part of the state.
Correct.
I want you to speak on that, please, for a minute.
So I would explain it. I mean, she's talking about the rural numbers. So rural hospitals close faster than urban hospitals.
That's right.
And that's because of the amount of people that don't go to the hospital because they take on a healthy attitude. So they don't be spending time going into hospital emergency care. So one of the things happens is, when you go in rural centers, you don't have triage centers there. You have hospitals there, they walk in, they want to see the doctor. They actually go to their doctor and their care provider. So if you have money, you go to your care provider, you don't go to the hospital. So this is one reason why hospitals in rural areas close, because they don't have the emergency room or the triage center running as rampant as into North. The problem there is you got flip side. In areas like urban centers, most of your people are uninsured, so they wind up not insured. In the rural areas, you have people who are insured. They have money. So they go to their doctor. They go to their care professional. So they don't even go to the hospital. So is a love-hate relationship with the hospital? Because if that hospital is underperforming means how many people they're servicing per year and how much money they're getting from that community. And then in rural areas, because they have money, they take care of themselves, they go to their service physician and everything, they don't fill up the hospital beds as fast as the hospitals being filled up in the urban centers. And that is a bad and good thing at the same time. And as a result of that, those hospitals close faster. And so they're not making profit off of the rural areas.
And also for South Jersey, I know for sure, right. for South Jersey, you have, of course, they're smaller hospitals.
Correct.
They're only 40 some beds or less in
That's
the
correct.
hospital. They cannot afford a ventilator.
That's correct.
Many of them are isolated. They can't afford ventilators.
Right.
They can't afford even the $10,000 ventilators.
Right.
Transportation is a problem in
Correct.
South Jersey, in the rural areas.
But
So
transportation is a problem in Jersey, because when you close all those hospitals that you close, if you live like in the city of Plainfield, like I do, in Muhlenberg was like 3 minutes to 5 minutes from my house. Now I have to go over to Edison. There is no bus service that runs from Edison to Plainfield, although they did put in, as a result of the closures of Muhlenberg, they were required to put in transportation from Plainfield to JFK. Of course, and you and I both know how well that runs, okay? But what I'm saying, if you look at New Jersey, if you look at New Jersey, you look at Camden, okay, you look at Atlantic City, and all those things, and there was transportation in the bill that was provided by the state of New Jersey that required that New Jersey Transit would provide transportation to those locations where there was no transportation required when the hospitals were local. So when you lose the hospital, you have a wild card in that whole piece, okay, is how do I get there? Okay, and so no one has really talked about that, and nobody has really investigated how well the transportation system is actually working, okay? And if you talk to people who go to the hospital, they'll tell you how well it's not working. Okay.
And also, we have to begin to really customize what we're saying, because Cape May is totally different from Camden County, and Atlantic County is totally different from Cumberland County. So I think a lot of information, and I'm talking still about empowerment, a lot of information has to be looked at from a county perspective and not necessarily North Jersey and South Jersey.
I'm not even looking at that. I'm looking at
because of the
Diane, allow me.
Local areas that aren't there anymore.
Yeah, I'm agreeing with you. I agree with you 100%, because the transportation in Cape May County, even though the county isn't poor, so to speak, in some areas, still and yet the transportation is a challenge. The transportation in counties that are like in Gloucester County, and transportation in the rural areas of Atlantic County, Newtonville and Nisbah and all of them, they have nothing. They have nothing.
That's true.
Allow me
and I think
to talk about Essex County, because you have folks in Essex County. Once you get out of Newark, get on the other side of Irvington, you need $1 million to buy anything. And so, being chair of the Human Service Advisory Council, we know where our pockets of problems are for services and especially healthcare, and that's in Irvington, Newark, East Orange. Orange is starting to creep in there. Newark being the largest, if you will, the largest in the state. The other thing dealing with an urban center, and I'll take Essex because you can go to Essex Fells and be up wonderful. Various sicknesses, if you will. For example, if you live in Essex Fells, your kid may do well. You live in Newark, you're still dealing with lead poison, lead in the water. You're still dealing with asthma, which is unbelievable because it's a concrete jungle. You can go 10 miles up to Roseland and get your horsey out, you know, and people are saying, and that's why you have to do what I call, and what we were taught in corporate, and Diane knows this, market segmentation. You've got to look at the segment of the people that you serve, and the market may be totally different. I sat in those corporate rooms, being the only one that looked like me, and we were and Bishop and Diane, you know, I'm right. They would say, well, they're a secondary market. They're a subset, and I would say I'm not a sub anything. The minute you put sub, if it's not a sandwich, it means I'm beneath somebody. And so even the mindset of the powers, and then our people have to stop selling out. I'm just going to throw that out there. Our people got to stop selling out. And I can say this from part of being a Black clergy. You offer me, Mr. Politician, a job that puts some money in my pocket. Very few will not sell out. Well, you know, I'd be with you, but you know, no, I don't know. I don't know. And this is the clergy in me, and I got enough people mad at me, and so I really don't care. But and regardless of what you believe, what profit you to gain the whole world and sell your soul? And what happens when you get sick?
I would.
We're going to wrap up here.
Okay.
I just want to comment on one thing.
Let me just finish my piece because I'm trying to get it in. In terms of healthcare empowerment, educate, and I think we all know education is key, legislation, communication, especially, and this is one last thing I think is so critical, is community assessment. African-American women have the highest level of depression than any other group in the country. And yet that is going unattached. It's not being put out there the way it should. But here's something I wanted to say, and I know you got to wrap this up. I wanted to say, and I think Bishop James would appreciate this, we need a roundtable of stakeholders. We need the legislator at the table, the educator at the table, the consumer at the table, the hospital administrator at the table, the insurance person at the table. I talked to one insurance person, they said they would come. They can't control the policy, but what they would do is take the perspective of everyone at the table and take it back, and they will have to take it into consideration. One insurance person said, no, I wouldn't do that. But here's my point. My point is, if we as healthcare, if we truly want to empower, then those groups need to come to the round table. Hopefully decision makers at the round table. Bill Bishop, because of his statistics, would be at the round table. Bishop James at the round table. Brother Gore at the round table. And I'm saying that because that is going to help us to be prepared when a hospital says they want to close. We are ready to go. We have the cultural necessity. We have the tools. We have the plan that we're going to put into place before it closes, not after it closes, before it closes, because we have to deal with and pay attention to sustainability, keeping something open. Thank you. Thank you all for adding to my presentation also. Appreciate it.
So I would say Donna is correct. And from my point of view is I not only just do the statistics, I actually plan stuff out. For example, I have the data from the ridership for New Jersey Transit and how many people actually ride their buses in certain areas. And that's one of the address in areas of rural areas. Most people in rural areas drive their cars and they go and they can transport because they can afford to. But we're getting into areas now where we're trying to deal with emissions. And so, but rural areas will get into areas where they'll have electric cars and be able to afford to drive electric cars. Where
there's a lot of poverty in rural areas, though.
That's true.
That are not talked about and not touched, unfortunately.
So,
believe it or not, there's quite a bit, but they're isolated and we don't talk about them enough.
Right. So one of the problems is planning. And when you get on here, planning has to bring in, okay, what's this neighborhood have? And you got to plan what
community assessment. That's right.
Do the assessment in order to make that happen.
Absolutely. Concur.
Yeah.
I concur as well. The needs assessment, and we do it on a regular in Essex County, again, in the Human Service Advisory Council. However, on the boards that I sit on, I remind the hospital, you're open because of us.
Right. Especially
like Prime, because they own several hospitals within the state. And then I also do comparison. If you're doing it, and I'll just take, and Diane, you know, you're one of the few people that say Montclair. Everybody I know from Montclair always said I live in Upper Montclair. Same thing.
Yeah, that's true.
Yeah.
That is true. That is true. And the reality is that whatever disease that we get, poor people get, guess what? The pandemic is not discriminating.
That's right. That's right.
And so we need to come from this, as Diane said, a round table.
That's
all
right.
entities at the round table. We were able to do it successfully for St. Michael's. But then after you get what you want, you've got to keep on keeping on to keep what you want.
Sustain. That's right. Sustain it. That's right. I agree 100%.
Also, legislation also affects a lot of your insurance. So your legislators also has to be aware of listening to those numbers and make educated decisions. Most of my time, I compare what is already in the legislation and show the positives, the pros and cons. And everything has a coin. The coin has a heads and tails. And you have to plan both and get the best results of it that will make sustainability work.
All right, I want to thank you guys for joining me today on this panel. I think we brought up a lot of issues that we have talked about, that the minority community is probably most affected by this, because we tend to have people who have less money to be able to afford the health care. But one of the wild cards in all this thing is that we never ever talk about the fact that we also have less transportation.
True.
And that the Transportation Act that was enacted by the governor and the things to take care of themselves was woefully inadequate. And nobody addressed it at the time that it did. But it says that we have a lot we have to do. We have a lot of things that we need to be addressing as a community. And if we don't address it, it's not going to get addressed. So one of the things we need to understand is that all of us need to start stepping up, standing up, and being counted as we move forward. And in this pandemic, but the pandemic is not over, okay? But the pandemic is worsened by the fact that we have a lot of underlying issues that have not been addressed. Again, 2 years ago, you had 150 hospitals. Now you have 113 and still going down. And the places that are going down, by and large, are in communities that serve a lot of minority people. It's being replaced in some places by health centers, but those health centers have their own anomalies. So there are a lot of things that we need to pay attention to as a community, and so that we better serve our people. And as we move forward, mental health is going to be a major issue now due to the pandemic. And I don't think we have a lot of mental health facilities, especially in minority communities. But thank you all for joining us. Looking forward to continuing this on, and you have a great day.
Thank you.
Thank you.
God
Thank
bless
you.
everyone.
God bless.
God bless.